geographies applicable to Uganda include the importance of effective risk communication messages, improving the health workforce surge capacity, and the importance of ensuring a comprehensive approach to all services to avoid neglecting some services such as mental health. Next slide. Yeah, I'd just like to end by acknowledging the project secretariat at Makerere University School of Public Health, our research partners in Nigeria, Senegal, and DRC, as well as our partners Gates Ventures and our funders Bill and Melinda Gates Foundation. Thank you. Over to you, Dr.
Thank you very much, Stephen Kawama, for sharing those lessons in maintenance of essential health services in Uganda, DRC, Nigeria, and Senegal. We are now moving on to the next panelists from the World Health Organization, Dr. Teshome Desta and Dr. Abera Alemo. This was supposed to be our first presentation, but we are now taking it as the second for those who have just joined us. And please do post your questions in the chat if you would like to answer any questions or clarifications. Dr. Teshome is a medical doctor and a specialist in pediatrics and child health with over 35 years in medical and public health practice. He previously also worked in academia and was an associate professor, and is currently the regional advisor for child and adolescent health in Eastern and Southern Africa under the WHO regional office in Africa. And the other panelist for this presentation is Dr. Abera Alemo, who is also a medical doctor and has also extensive experience in public health in Ethiopia, as well as other countries in sub-Saharan Africa. And he's currently a regional advisor and consultant to the World Health Organization office, AFRO, for sub-Saharan Africa. And he is supporting the efforts to assess the impact of COVID-19 on continuity of essential health services, including maternal, newborn, child, adolescent, and the aging health services across 5 countries, including Cameroon, DR Congo, Ethiopia, Nigeria, and Uganda. Welcome, Dr. Teshome and Dr. Alemo. The floor is now yours for the next 15 minutes. Thank you.
Thank you very much, Prof, for this opportunity. Can you see my screen?
Yes, we can see your screen.
Yeah, okay, thank you very much. Steve has already presented for the 3 of our 6 countries, so I'll not spend much on that because most of the issues are the same. So the outline of our presentation is as follows: a brief introduction, and then we will share some key highlights from the WHO Health Survey in January, March this year. We also share some key highlights and lessons from the WHO initiative on the mitigation of COVID-19 on MNSH services in the 6 countries that Prof has mentioned. And we'll also share some key lessons and some challenges and concerns, and finally, a way forward. So the objective of monitoring of continuity of essential services is really to detect and estimate the level of disruption of essential services as soon as possible in order to trigger corrective actions, and also to ensure access and utilization of quality essential health services in order to prevent increase in mortality, morbidity, fertility, mental and physical ill health, and contribute towards the achievement of the SDG goals. So what are some of the factors affecting access to essential health services during the COVID-19 pandemic? We have supply side factors as well as demand side factors that will influence the coverage of essential health services during the COVID pandemic. Some of the supply side factors has been mentioned by the previous speaker. I don't need to dwell a lot on that, but basically some of them are like designation of facilities for COVID care or closure of facilities, and resource shortage, especially redeployment of human resource and budget diversion, as well as a shortage of PPEs. From the demand side, it has been already highlighted in the four countries: lockdown measures, movement restrictions, fear, stigma, misinformation, and also community concerns about quality and safety of services. So these are some of the factors. So WHO has conducted a second pulse survey. The first survey was conducted for the May to July, and the second survey was covering January to March this year. In this pulse survey, 135 countries and territories participated in the pulse survey on continuity of essential services during the COVID pandemic. And 40 of these countries are from the African region. And the findings offer insights from country key informants into the extent of the impact of the COVID pandemic on essential health services across the life course, and also the reasons for those disruptions, as well as the strategies and approaches taken by countries to maintain service delivery during this pandemic. The findings of the two rounds of this survey highlights the need to improve real-time monitoring of change in service delivery and utilization beyond pulse surveys. The full report links are attached with this presentation. Here you will see the average level of disruption across 63 tracer services in 40 countries in the African region. So in summary, you can see 95% of the 40 countries reported one or more disruptions to essential health services, with an average of 42% of service disruption, at least partially, in each country. 8% of the services were disrupted by more than 50%. So severe disruption was not that common. I think this is a point we need to note. Only 8% of the services were disrupted by more than 50%. Another 8% of services were disrupted between 26 to 50%, and 26% of the services were disrupted between 5 to 25%. As you can see, the green bars stands for service disruption between 5 and 25%. So 7 of the 40 countries have green bars. And you can see countries with longer red bar have countries that have more than 50% of disruption of essential services. And this slide shows you the level of disruption for 8 tracer services. So you can see most of them are in green, meaning the disruption was between 5 to 25%. And the red indicates a more than 50% disruption, but fortunately, they are not that common. This slide shows you the reasons for service disruption. As you can see, the most frequent reasons are insufficient staff availability for various reasons, either redeployment or fear, and followed by community fear or mistrust in seeking care, financial difficulties during the outbreak, and as well as insufficient personal protective equipment, travel restrictions, unavailability stock out of essential medicines. So fortunately, closure of outpatient services or closure of outpatient clinics were noted only in 6% of the countries. So closure was not really a common reason for the disruption of essential health services during this pandemic. So what are some of the strategies or measures that countries have taken to overcome the challenges and in order to maintain continuity of these essential services? Community communication was one of the commonest measures taken by most countries because community mistrust, fear, and so on was common. Recruitment of additional staff, triaging to identify priority cases, redirection of patients to alternate sites, provision of home-based care where appropriate, self-care interventions, task shifting, and innovative approach in dispensing approach for medicines, especially chronic care and so on, integration of several services into a single visit, and also changes in prescription approach. Some countries were authorizing community health workers to prescribe some medicines like iron folate and so on. So government removal of user fees was noted in about 8%, expanding facility working hours in about 11%. So these are some of the strategies taken by countries to overcome the disruptions. So now we're coming to the WHO initiative on mitigation of the COVID-19 on MNCAH services. Basically, this is a kind of framework to collect information and analyze and synthesize that will be used for decision-making or response to mitigate the indirect effect of COVID. So WHO has supported the 6 countries, Cameroon, DRC, Ethiopia, Nigeria, Uganda, and South Africa, where we have 1 or 2 national consultants to give an extra pair of hands to the WHO staff, where most of them have been repurposed to COVID response to support the government efforts to respond to COVID and maintain continuity of essential services by working closely with the technical working group in order to adapt effective strategies, guidelines, and SOPs. This was really implemented within the health system context, focusing on governance issues to make sure they have a national plan for continuity of essential services, representing in the technical working group, working with the incident management team, mobilizing partners, and also on the guidance, like I said, developing guidance, SOPs, and also in the area of information monitoring key RMNSH indicators on monthly basis, producing dashboard and giving feedback to the Ministry of Health for decision making, and also actions to mitigate the impact. So the overall effort was really to make the response effective in maintaining RMNSH services. So we have monitored a set of core RMNSH indicators on monthly basis. Some countries have selected 20, 18, less than 30 anyway. So these are some examples to show you how the trends of these indicators are in terms of recovery. In summary, the core RMNSH indicators have shown different trends of recovery in different country contexts, but looking at the SRH family planning, we have observed variable trends in service delivery across countries. And if you take Ethiopia, the number of women receiving comprehensive abortion care services decreased throughout 2020 after the onset of the COVID pandemic. You can see still much lower than the 2019 trend. We have also noted increase in number of gender-based violence in 2 of the 6 countries, in Uganda and DRC, as you can see. We have also noted increase in contraceptive distribution and use in all countries except for initial drop. in South Africa and Uganda, which quickly picked up after about September or so. Coming to maternal newborn health, we have also observed fluctuations in delivery of several MNSH services in 2020 compared to the previous year, 2019. The numbers of PNC contacts for mothers and newborn care varied across countries. Facility births reported from little to no change in some countries, or increase or decrease in others. So if you see the trend in DRC, it is performing much better this time around than the previous year. But we have a lot of reasons behind this observation. In child health and immunization, also we have variable trends in childhood prevention and treatment services, but immunization or vaccination was one of the services that has been affected in many countries, even beyond these 6 countries. So there was a drop in vaccination coverage in DPT3, Penta3 antigen, and children seeking care for diarrhea, ARI, malaria declined throughout 2020 in most of these countries. In the second WHO Pulse survey, we have collected very important information around digital health to see the percentage of countries reporting the use of health technologies to support service delivery. You can see it has been used in many ways to provide service for consultation, for scheduling, and so on. And we have also collected information on percentage of countries reporting barriers to use of health technologies, starting from limited access to health technology to limited organizational and technical capacity, infrastructure capacity, and so on. We have also noted that the high-income countries have used digital health technology most, almost 96%, close to 100%. So in summary, we have noted that during this pandemic, there has been a substantial upsurge in digital health interventions to maintain communication with different levels, with health workforce, service users, and other activities such as capacity building and teleconsultation.
Dr. Teshome, may I request you to wrap up in 2 minutes?
Yes, I'm almost there.
Thank you.
Some of the key lessons is really the need for a coordinated emergency response involving the incident management team, the health system departments, and the life course and disease-specific programs, as well as implementing partners, is really critical for a unified response. Achieving a balance of measures to mitigate COVID-19 infection with actions to maintain the delivery and use of essential services would require a specific plan for maintaining MNCH essential services as part of the country integrated plan for emergency preparedness and response. I think it's important to note that this response cannot be handled by the health sector alone. So it really takes a whole of government approach in order to ensure effective response. The central importance of support for health workforce, including their physical protection, as well as their mental health needs, capacity to assume new tasks, was stated by most countries without undermining the importance of financial motivation. The role of the private sector is really important to emphasize here in many ways. And some of the challenges and concerns are really in the area of new waves of COVID coming, virus variants, and vaccination. This has been major issues of concern. And with regard to the COVID-19 campaign, we have seen redeployment of health workforce, diversion of medicine supplies, resources, and finances as issues of concern. Data is really a powerful tool for monitoring services, but data quality analysis and visualization and use for decision-making continue to be a challenge. I think some of these are more of, I think one thing that I want to emphasize is we should not be deceived by the apparent recovery or return of services to baseline of 2019 or previous year, since this may mask a different trajectory for some vulnerable and most at-risk individuals and communities, whereby prolonged disruptions may go undetected and result in severe health impacts, basically due to limited administrative data on the health of some population groups or less attention to these groups. So finally, I would like to highlight some points as a way of forward. It is really critical to strengthen coordination and collaboration with relevant program stakeholders, including the incident management teams. And it's important to continue monitoring of continuity of essential services, using real-time data to inform policy decision and programming. And it is also critical to strengthen advocacy for data sharing by member states to inform public health emergency response, ensure continuity of essential services. And it is also important to integrate MNCH actions into the country preparedness plan for future events, emergencies. And finally, we need to continue and support documentation and dissemination of best practices so that we'll be better prepared for future similar events or emergencies. So these are some of the people who have contributed to this presentation. And thank you very much. Asante sana, Sukomo, Amsegnalo, Merci, Tatenda, Nagode. Thank you very much. Over to you, Prof.
Thank you very much, Dr. Teshome, for sharing those experiences from the WHO work across countries in Africa. I will now hand over to Professor Faule, who has finally been able to join this session as co-chair to introduce our next speaker from Rwanda and from the World Bank team. Welcome, Professor Faule, to take us through those two sessions.
Okay. Good morning, everybody. I hope you can hear me. Good morning, everyone.
We can hear you, Professor Faule.
So thank you very much, my co-chair, Dr. Wanyeze, for holding forth while there were minor issues. Now we move on to the next presentation. Of course, thanking Dr. Voldehana for his beautiful presentation, where he was sharing the work of WHO Afro on maternal, newborn, and child and adolescent health as regards essential services during the COVID-19. The next presenter is Dr. Alemayehu, who is also speaking on the essential services. His presentation is titled Maintaining Evidence-Based Interventions for Maternal and Child Health Services during the COVID-19 outbreak in Rwanda. He's telling us or presenting to us an implementation science approach. So Dr. Alemayehu is a very well-known scholar, and he is a medical epidemiologist of over 13 years of work experience, and he has worked both in the academia and on field research. His countries of exposure include Ethiopia and Malawi. Dr. Alemayehu was most recently the Implementation Science Director at the University of California, Los Angeles, and he was based at the Partners in Hope in Malawi. He is currently working as a doctoral scientist at the University of Global Health and Equity based in Kigali, Rwanda. Please, Dr. Alemayehu Ambabiri, the floor is yours. Over to you. Thank you.
Thank you so much, Professor Fami, for that kind introduction. Can you see my screen?
Yes, I can. Please go ahead. You're on the floor.
Thank you so much. Title of the presentation is Maintaining Evidence-Based Intervention for Maternal and Child Health Service during COVID-19 in Rwanda, which is an implementation science approach. These are the outlines of the presentation: COVID-19 in Rwanda, implementation research in exemplars for under 5 mortality, brief description of the methods, some findings, and we'll end the presentation by concluding. So, as the previous speaker indicated from the WHO second round pulse survey, nearly 94% of the 135 countries and territories that participated in the study reported a disruption in essential health services, and most of the services disrupted include reproductive, maternal, newborn, child health, and adolescent health, and nutrition. And coming to the COVID-19 in Rwanda, until recently, we have just over 6,000 confirmed cases and around 420 cases reported so far. And in terms of the response to the COVID-19 in Rwanda, Rwanda showed an exemplary response to COVID that include rapid enforcement of non-COVID-19 evidence-based interventions, including border closing, lockdowns, etc., and infection and prevention and control practices. Equitable approach to the COVID-19 response, particularly welfare support and free testing, contact tracing, isolation, and quarantine, and adoption of various technologies. Our study objective is to look at if and how evidence-based interventions known to reduce under 5 mortality were maintained during the period of COVID-19. We looked at implementation strategies used to prevent or respond to these evidence-based interventions. These evidence-based interventions for under 5 mortality include the vaccination, facility delivery, neonatal care, etc. What contextual factors helped or hindered the success? Where did we see evidence of health system resiliency? So coming to the methods, we conducted an implementation research just to highlight that implementation research is basically research that fills the gap between the evidence-based intervention to a significant health problem. So there is a research that provides evidence, and there is a practice or implementation research evaluating strategies that help us to integrate evidence-based intervention into a real-life setting. So our overall approach, we build on under 5 mortality exemplar work that highlighted by the first speaker. Basically, we used a hybrid implementation research framework adopted from the previous work that looked at how and why Rwanda outperformed in the reduction of under 5 mortality between the period of 2000 to 2015, looking at a number of implementation strategies and a number of contextual factors at a different level from a global Ministry of Health to national level. So we adopted those implementation frameworks, and we also utilized the health system resiliency framework from Crook and colleagues that encompasses 5 key domains from adoption, self-regulating, diverse, aware to integration. Coming to our approach, the first approach we used was desk review, looking at the PubMed Medline searches, multiple country case report, and in-country guideline and reports. Other data sources include the key informant interviews. We conducted 21 key informant interviews included in the study. These key informants were selected from various stakeholders within the health system, ranging from MOH, Ministry of Health to a private sector. And then we utilized HMIS data for quantitative analysis that ranges, the time varied between January 2017 to February 2020 as before COVID, and March 2020 to December 2020 during COVID period. For the quantitative analysis, we utilized an interrupted time series analysis, as I mentioned earlier, prior COVID from January 2017 to February 2020, and then during COVID, March 2020 to December 2020, and we utilized a Poisson regression to estimate the impact of COVID. And for qualitative analysis, interviews were transcribed, and we used standard qualitative software. Coming to the results, first to our quantitative findings from analysis of the HMIS data, looking at this scatter plot for the vaccination, the TP3, HPV, and the HIP3, the pentavalent vaccine, and the rotavirus vaccine. Looks like vaccination coverage maintained well before and after, before and during the period of COVID. Then if you look at the scatter plot, there is clearly, this is across the 30 districts in Rwanda. There is some level of subnational variability, whereas the mean predicted for Rwanda remains well maintained. Looking at, it looks like there is a slight increase in antenatal care coverage attendance, whereas the fast delivery maintained well, but clearly there is again some level of subnational variability across the 30 districts. There is a drop in diarrheal cases treated both at the facility and at the community level during the period of COVID. So clearly there was a reduction in OPD attendance as well as community health attendance for both for diarrheal disease as well as for pneumonia, a drop in pneumonia cases treated both at the facility and community during this period. Coming to the key informants findings, the change in essential health services. This is a report from the key informant at various levels. So that shows you some sort of variability by facility, by a district. For example, in some facility, some key informants reported some sort of a slight drop in coverage of vaccination, a decrease in OPD consultation, some sort of change in antenatal care coverage, facility-based delivery, and interruption of gross monitoring. But generally, recovery of service was quick, and service bounced back after the first few months, usually March, April last year, and there was strong community sensitization, collaboration across partners. So key takeaways include some of the cause of the reduction according to the key informants include challenges of transportation, community and healthcare workers fear shortage of healthcare workers, particularly in the early phases of the pandemic. And there was also some sort of change of a disease pattern, including reduction in infectious disease due to school closures, lack of mass gathering, wash intervention, etc. So what are the implementation strategies that help to prevent or respond to this evidence-based intervention drop, for example, antenatal care or fast delivery or vaccination? This include, there are a number of implementation strategies. Some of the most important one include community-based healthcare delivery, data utilization of data use for decision-making, the mentorship and supervision, provision of transport, community engagement, the use of digital platform, particularly using WhatsApp group for monitoring and evaluation indicators, using WhatsApp group for professional associations, professional members, to make a clinical decision. The policy is another implementation strategy. For example, ensuring that essential health services shouldn't be disrupted. Donor and implementing partner coordination is another key strategy. The focus on equity, particularly redirection of funding to support the vulnerable group, or provision of welfare support, for example, nutrition support, etc. And then leveraging existing system is also one of the key strategy. For example, leveraging the previous Ebola epidemic preparedness, and then utilizing that, learning that lesson into a COVID response, and then the development of the command post or some sort of an emergency response team from the national level to lower level are also one of the key implementation strategies. So just to highlight some of these, for example, for the response to COVID-19 that's supposed to maintain the evidence-based intervention, community health workers and health facilities were provided with PPs, additional vaccination days, for example, that helped maintain some of the EPIs, a toll-free number, and other COVID-19 preventive measures that support to maintain the essential health service. The community-based healthcare delivery, utilizing community health workers to identify children who missed vaccination, education, and a focus on primary health care, as well as visiting the schools by the community health workers. Data use is another important implementation strategy that helped prevent the drop. Review of data at the lower level of care. Partners use the same HMIS data platform and analyze, make a decision at coordination. And the use of electronic register is also another data use. Mentorship and supervision is another one, a technical mentorship group, particularly by clinician moving around the districts due to problems with the referral for neonatal care. Supervision of community health worker via telephone, and then limiting number of supervisors per vehicle, but still continuing supervision. So bringing this into context, what are the facilitating contextual factors that helped the implementation of these strategies? Those include the collaboration, coordination between particular donors and implementing partner, community health worker, the existence of the community health worker system, the system of learning and improvement, the data availability, supply chain system, the leadership and control, and the culture of accountability. So highlighting some of these fascinating contextual factors, for example, for collaboration and coordination, existence structure of collaboration through the National Strategic Plan that prevents duplication of effort in this during this pandemic. The extent of this community health worker system, a strong facilitator at community level, the system of learning and improvement, particularly regular monitoring and evaluation of supported identification of disrupted health services, data availability of data through HMI, centralized data reporting system, and the supply chain system, strong supply chain prevented stockout, for example. What are the challenging contextual factors? So, despite those important faceting contextual factors, there are a number of challenging contextual factors as well, particularly I think the one related to lockdown, movement restriction that prohibited transportation. And a stockout generally is not a big problem in Rwanda, but there was some issues in some facilities, in some districts due to the disruption of movement. The community fear of COVID-19 was particularly an issue at the early beginning. And then workload, staff shortage was also some sort of an issue at the beginning, and healthcare workers' fear of COVID-19 was also one of the challenging contextual factors. So where do we see health system resiliency in the Rwandan health system, putting these the previous implementation strategies and contextual factors into context? So clearly there was some adaptability of the health system, strong motivation to adapt strategies. There was task shifting happening, there was budgetary allocation happening, and there was also awareness of disruption of the essential health service through regular evaluation of data and local decision making. Continued maintaining of core function, prioritizing essential health service and critical follow-up of patients with other conditions, and maintaining straight line of communication and referral between different levels of system. And all service delivery activities continue with support of leadership despite the threat of the pandemic. What lessons have been learned? So some of the transferable lessons identified from our key informants include that helped for the Rwandan health system to respond or mitigate the drop in the evidence-based intervention for under 5 mortality, include investing in health system and then leadership at all levels, coordination of activities, particularly between donors and implementing partners, data use for decision-making at all levels, ownership, timely information, public trust, and then innovation and the focus on equity. In conclusion, Rwanda maintained most of the evidence-based intervention for the reduction of under 5 mortality during the period of COVID-19. Example, vaccination first delivery. Service bounced back after the first few months, particularly during the March and April last year. Lockdown and movement restriction and fear of COVID by the community as well as healthcare workers were barriers to service delivery, particularly in the early period of the epidemic. Key implementation strategies used to prevent or respond to the evidence-based intervention include community health, the extent of the community-based healthcare delivery, data use for decision-making, mentorship and supervision, provision of transport, community engagement or education, and the use of digital platform. The ability of the Rwandan health system to adapt encourages flexible response to fit situation, but we call it health system resiliency. And then some of these transferable lessons include investing in health systems, leadership, coordination of activities, data use for decision-making, ownership and accountability, and the timely communication and public trust. So these are my acknowledgements presented on behalf of my team and the Rwandan MOH in-country partner, the Gates Venture, and the Bill and Melinda Gates Foundation for funding this study. And then, of course, our key informants who generously provided their time and insights. Over to you, Professor. Thank you very much.
Okay, thank you very much, Dr. Amber Burr, for this enriching perspective on maintaining essential evidence-based intervention for maternal and child health during the period of the COVID-19 in Rwanda, an implementation science approach. It was very enlightening. Our next panelists are Dr. Tashkir Ahmed and Jean Rusatira from the World Bank Global Health Financing Facility. Dr. Rusatira is a result-based financing consultant at the Global Financing Facility Secretariat in the World Bank. He is responsible for providing technical and operational support to design, monitor, and implement result-based financing in countries with GFI portfolio. Jean's experience working in low-income and fragile settings include Rwanda, Congo-Brazzaville, Laos, Cameroon, Guinea, Chad, and Yemen. Most recently, Jean is contributing in rapid monitoring of essential health services in GFF partner countries to estimate disruptions in delivery of routine health services due to the COVID-19 pandemic. Dr. Ahmed is a consultant with the Global Financing Facility for Women, Children, and Adolescents. Since 2000 May, Dr. Ahmed had led a team in conjunction with the World Bank Development Research Group, DC, in conducting rapid monitoring of essential health services in GFF partner countries to estimate the disruptions in the delivery of routine health services due to the COVID-19 pandemic. Dr. Ahmed previously managed the infectious disease modeling and COVID-19 analytics for the Washington, D.C. Health Department to inform strategic response and vaccination rollout. He was previously a faculty member at Johns Hopkins University, country director for a CDC program in Liberia to support the redesign of the disease surveillance program following the 2013 to 2016 Ebola epidemic. Dr. Ahmed and Rosatira, we are looking forward to your presentation on monitoring essential health services during the COVID-19 pandemic. The floor is yours.
Yeah, thank you, Dr. Fawale. Can you hear me?
Yes, I can. Please go ahead. The floor is yours.
Yeah, thank you. So we are pleased to present our work on the monitoring of essential health services during the COVID-19 pandemic. So I will quickly talk about some objective, and then I will leave the floor to my colleague, Dr. Tashrik, who's gonna talk more about the methodology and finding. Next, please. So the objective of GFF activity in supported to our country portfolio. So we really focus on rapidly identifying and quantifying service disruption due to the pandemic using the STATA software to inform health services intervention, and also to create a body of knowledge to inform preparedness effort for future crises. We also intend to place some particular emphasis to the need for capacity building and sustainability within countries. So because we have seen that this has the value of this monitoring exercise as an ongoing tool that should be integrated into a routine health surveillance exercise. Next, please. So these slides summarize the overall support to country in this work, but today we are really presenting the HMIS activity assessment as a part of the large portfolio. So in panel A, we can see that our support that we provide to country to monitor the HMIS services volume for key services. In panel B, we discuss the implementation of rapid facility assessments through phone survey, which give us more context on HMIS services disruption and allow also some qualitative feedback from the field. In panel C, you can see that we also triangulate with supplementary data, particularly through a country dialogue platform. And also, there are also some other household surveys that are conducted by the World Bank on demand side in the effort of having more complementary information. And then finally, in panel D, it's about our overall contribution to the global knowledge by developing a multi-country analysis. Next, please. So this slide just summarizes the support to some countries. So we have active HMIS monitoring exercise in 21 countries, but also ongoing or upcoming rapid facility survey in 10 countries. I'll quickly give the floor to my colleague, Dr. Tashik, for the following slide. To you, Tashik. Tashik, we can't hear you. Are you there?
Or do you continue the presentation if it's not there? Would you continue?
I think it's coming. So this, okay, sure. So this really, it's the methodology on quantifying the disruption. So we first identify data from the HMIS, mainly the DHIS2 from countries, and then there is a data processing, and then we also develop a counterfactual that would to show that the volume of service that have been how the service could have been without the pandemic, and then we have some consultation with the countries to discuss the primarily the draft's findings, and then also we triangulate with other sources, as I said previously. Next. So here we have analysis on facility data quality adjustment, and we first analyze the data completeness. Also, we identify outliers I have some returns from my.
It looks like we have Dr. Rusatira back.
Jean, are you able to hear me now?
Oh,
yes,
I'm hearing you though.
Apologies, I had some technical issues. I have joined by phone now.
Okay, please, you have the floor. You can continue where Dr. Rusatira stopped.
Okay, I am not able to hear.
Take a few minutes to get your bearings. Please go ahead.
Okay. I assume that you can hear me, though I can't hear anyone else, but I'll continue the presentation. So as Jean said, this slide is summarizing some of the data quality checks that we run with the data. There's often some hesitancy in using HMIS data. So in order to make sure that the analysis is robust, we look at two very specific elements. So the first is data completeness on the left-hand side. And we're showing here the completeness for outpatient consultations on the left-hand side of this image. And on the right-hand side is family planning. You can see that in most countries for outpatient consultations, the completeness or the number of facilities which report in a given month is quite high and quite steady. So above 75% for most months, and the month-to-month fluctuations are quite small. So we consider this to be relatively reliable data. And the big concern here is looking for completeness drops right after the pandemic period. Other indicators such as family planning, however, have very variable completeness. So it is a country by country decision on whether to include it and talk through the data quality. For outliers, we have a outlier algorithm that can go through on a facility level and look at outlier values. And here in this example from Cameroon, you can see some clear outlier values in outpatient consultations and polio, which were caught and removed from the analysis. So with these two data completeness checks, we're able to get very clean data, and by doing this facility level adjustments, we're able to unlock this HMIS data for further analysis. Next slide, please. So once the data are clean, the question then becomes, has the service volume changed since the beginning of the pandemic? And on this slide, you can see an example from Nigeria for, again, outpatient consultations, which we use as our general proxy indicator for overall health service utilization. The red line here demarcates March 2020, which is for us where we created the interrupted time series. And you can see right after this period, there's a drop in utilization. Next slide, please. On this data, we can then overlay our statistical model. And in this model, we take the trends in seasonality and trends over time and facility characteristics from before that pandemic period, so before that red line. And then we've used that information to forecast forward what the service volume would have been without the pandemic. And then you can see the service shortfall here is highlighted in that yellow area between those two lines. So when we use this forecast as our baseline service delivery that should have happened, and then we do this across the continuum of reproductive and maternal care, if we can go to the next slide, we can then see the final results from our HMIS analysis for the set of countries, where the 0% line demarcates the baseline of where we expected service volume to be, and then we can plot for each country the percent change month to month compared to that baseline. So here we have the 8 key indicators, starting with outpatient consultations and then going through the continuum of maternal, reproductive, and then the child vaccination services. These are our 8 key indicators in addition to other indicators that are local priorities. Next slide, please. So to do a quick review of the key findings here, one is that we find that all countries that we have analyzed experience drops in service volume in the first months of the pandemic. In some settings, these drops are minor, but in most settings, we've seen drops of greater than 10 to 50%, which we consider to be quite substantial. Next slide, please. The largest drops that we see across services are in the outpatient consultations and in child vaccinations. This is in line with what we know from qualitative research and just the changes in service delivery, especially in vaccinations, which largely stopped the large mass vaccination campaigns in those countries, at least until May of last year. Next slide, please. We do find that child vaccinations have returned to baseline and in some settings have rebounded to recover some of the shortfalls, but many countries had ongoing shortfalls in other services through the end of 2020. So this is an ongoing concern, especially as we see additional waves of COVID and slow vaccination rollout, that this question of essential health service continuity continues to be an ongoing concern. Next slide, please. And then as other presenters have pointed out, we don't see a clear pattern in the disruptions of these RM-instituted services. It seems like they are very context specific and influenced by the structure of the health sector and the different supply and demand factors that may be influencing these service utilization. Next slide. And then though you cannot see it on this graph, it is important to emphasize, as others have, that there is substantial subnational differences by both the geography and level of care. Most commonly, though not in all settings, we've seen that hospitals are the most disrupted and the clinics closest to the community are the least disrupted. And we see that urban settings are often more disrupted than rural areas, but that does not hold in all settings. Next slide, please. We also have conducted rapid facility assessments. I'll go through this relatively quickly since I know we're running short on time, but these assessments are a panel of the same facilities that are surveyed every month, and there's a set of modules. Next slide. But today I will focus in on some of the drivers of the service utilization. Next slide. Thank you. So to summarize the results from 3 countries with recent data, just to talk about some of the differences in some of these factors that may have caused the utilization. In Liberia, where we have results between November 2020 and March 2021, we found that most facilities with volume decreases reported that fear of COVID as a major driver in November, but then by March of 2021, that dropped from 68% to 15%. In Liberia specifically, we also found that there's a severe lack of medical supplies that was a primary driver, which was cited by over 90% of facilities with decreases. In Nigeria, we found that the 2 primary drivers in September 2020 were fear of contracting COVID-19 and lockdown restrictions. But subsequent rounds through May of this year found no clear primary driver. And finally, in Malawi, we also find in this setting that the reported decreases are largely attributable to fear of catching and specifically getting diagnosed for COVID-19 during facility visits. And in our most recent round of work, we've also seen some suggestive evidence that fear of the vaccine is also driving more recent disruptions. In Malawi, facilities have also generally adapted by consolidating their care visits, supporting self-care interventions, prioritizing high-risk patients, and extending prescriptions of long-term use medicines. Next slide. To quickly summarize some of the limitations of this work, we need to mention that in some contexts, lower data completeness may be due to problems in reporting and processing of the data by strained health systems, which would bias the results somewhat. We also report that due to inconsistency in quality issues, we cannot rule out that other types of reporting issues that could affect results. And of course, our results only provide a partial picture, particularly in context with multiple service delivery pathways. Specifically for DHIS2 systems, we're not capturing that private sector, and in some countries, that community sector as well. And finally, the disruptions to service delivery could also be in the form of lower quality of care, which would not be detected in this type of analysis. Next slide. So our final conclusions and lessons learned from this work are: 1, that there are clear disruptions to essential services in the first few months of the pandemic, but there are large variations in the pattern of disruption between countries and between different types of health services. It is critical to reinforce the interventions for utilization gaps with innovative modifications, and the need for this type of innovation has not decreased, even though we're 1 year into the pandemic. This is especially true for health services in contexts which have not rebounded to account for previous losses. And we've seen in previous crises that delayed action can lead to higher incidence of disease and long-term health crises. And we also want to emphasize the point that this work that is presented today from multiple panelists shows that HMIS data is a very powerful monitoring tool, and investment should be made to increase the timeliness, coverage, and data quality to keep this data high quality and controlled by the country for future crises. Next slide. And then finally, if you would like some more information on the methods and other data, here's a recently published paper that you can reference. Thank you, and back to you.
Thank you. Thank you. Thank you very much, Dr. Ahmad and Rusatira. And sorry about the challenges with technology. We did request for some additional time since we started this session late due to disruptions to the connections. So we have about 15 minutes to discuss the questions that have been posted in the chat. And if there's any other question, please do post it so that we can discuss it, and then we will move to the wrap up. I see we have a question from Raj Kumar, and this is directed to Stephen Kawama. Why the little disruption in Democratic Republic of Congo? Is it because the performance was already low? Then we have a question here from Dr. Gerard Mutunji, a commissioner from the Ministry of Health in Uganda. And I think this is directed to the WHO team. Could the reduction in diarrheal diseases be due to improved hygiene based on some of the interventions directed at COVID? And then there is also a question to the WHO team again, why the improved performance in the second phase of your analysis. You mentioned that we have some good reasons behind this, and those might